Hello and welcome to Social Distance Learning. My name is Dr Madeleine Glasbey and I'm a foundation doctor in the North East of England. I'm going to talk today about spotting the sick child. This talk was originally aimed at our new FY1 doctors, but I hope you find it useful. Please leave comments below or tweet at co_videos. Is it recording?
Yeah.
Okay. So we'll make a start on the presentation. So like I said, I'm going to chat through spotting the sick child and just a few kind of salient points that I've picked up from what's ended up being 8 months on PEDS due to staying there. It's quite a niche speciality, not everyone will kind of rotate through it, so I'm just going to touch on the basics that if ever you are in an A&E department where you are seeing paediatric patients as well, or you end up doing a rotation, just some of the kind of quick basic things that I think all of us should know as junior doctors going through. So the teaching's going to cover a few things. We'll obviously be skimming through most of them, and some of them could do with a whole presentation on themselves, but hopefully if you did do paediatrics in the future, you'll be able to touch on those in a bit more detail. So we'll start by trying to talk about the differences between spotting a sick child versus a sick adult, because there's obviously a few challenges in terms of history and examination, and you can use parents to help you and guide you, but there's a few differences there. What kind of system, so there's a good traffic light system that we can use to identify the most sick child and sort of risk stratify. Some ways of telling if a child's dehydrated. Some are quite similar to adults, but others are a bit more special to paediatric patients. And then we'll touch on something that I learned quite a lot about in my placement, which has changed names recently to a BRUE rather than an ALTI. We'll touch on that in a little while, but does present quite a lot to the PEDS A&E department. One big thing, which is a horrible part of PEDS, but incredibly important and something that actually I've found challenging but interesting in my time in PEDS, and you're a real advocate for non-accidental injury and safeguarding, so I think it's really important just to touch on that, even if we don't go into as much detail as should be warranted for that topic. And then we'll just do a little intro into paediatric prescribing, some of the differences between PEDS and adults, and then a couple of questions if we have time. So the challenges, obviously some of them are very obvious, so a little one can't always tell you where it hurts or describe the symptoms like an adult would, and also they don't always present with your band or set of symptoms. There can be some sort of more subtleties, or say with what we'd usually class as a normal UTI with dysuria frequency, it might be more subtle with kind of abdo pain off their food. Vomiting is very common in children, so they might have a different set of symptoms that will tell you a bit, sort of signpost you to a certain condition. Observations can be kind of very subtly off, but can indicate worse physiology than in adults. So remember, a low or hypotension in a child is a very late sign, so you don't really rely on blood pressure much in a child. There's certain times you would use it, but your clinical judgment of a shocked child and not waiting for a low BP to be your reason to act, otherwise it's a bit too late really. Tachycardia is an interesting one, often a subtlety of just a tachycardia alone. We've seen kids then come back a couple of days actually septic, whereas we were quite happy and reassured in their presentation initially, and you're looking back at some of the case notes that the one thing they had presented a couple of days before was a tachycardia, so that's something you take really seriously, especially if a child is afebrile with a tachycardia, because obviously it's a physiological response when you're febrile for your parameters to go off like that, but if it's not settling when a child's afebrile and looking a bit better, that can get your heckles up a little bit. A feverish child can benefit from just watching and waiting. Sometimes we've seen kids come in with temps of 39, 40 and they look horrendous, really miserable, hot, just cannot be bothered, and then about an hour later when they've had a bit of paracetamol they look like a different child and their parameters have all settled, and that alone can be really reassuring for a set of parents, and often you can avoid unnecessary admission and further investigation. The other thing again is obviously parental concern and anxiety. I think you need to use parents. Their hunches and intuition can be really useful, and obviously you see a snippet of a child, parent knows them inside out, but also parents do get really worried, sometimes unnecessarily, and we do see a lot of presentations to A&E, especially at the moment in COVID, which probably normally would be dealt in GP, so you have to remember that it's managing a parental concern, knowing when actually maybe you're missing something, but kind of taking that into account. So yeah, there's a really useful set of NICE guidelines in the traffic light system, which is brilliant, and I've relied on quite a lot in A&E when I'm not 100% sure whether, like I was saying earlier, a feverish child just needs a bit of time, a bit of Calpol, a bit of watching and waiting, or whether actually this child needs bloods, it needs chest x-ray, it needs urine doing, it might even need an LP. And the traffic light just really helps you risk stratify, like I was saying earlier. So as this table demonstrates, it's sort of set into 5 different areas. So you've got a colour of a child, so that's touching on whether a little one looks really mottled. Obviously cyanosis is a big red flag. Pale, so little ones coming in just looking really washed out can sometimes be kind of a subtle sign of them not being quite right. Activity is a really big one, and I think fever can really alter an activity level. So you'll see a little one really lethargic, just can't be bothered, and often when their temperature drops, they're then running around the waiting room, and I think parents get quite frustrated sometimes because they've seen a GP, been referred by a GP being really worried, they've had Calpol by triage nurses, and we see them an hour later and they look absolutely fine, and parents are a bit like, you haven't seen them at their worst, but actually that's really reassuring, and we've kind of done the job by watching and waiting a bit. Obviously, if that's not the case, so a child is either still feverish or the fever's come down and they're incredibly lethargic, drowsy, floppy, that's a big red flag, and again, that's one to rely on parents a little bit more for, because you don't know what the child is like normally. If it's a little infant who's normally really smiley, alert, interactive, and is just kind of inconsolable crying, or really floppy in mum's arms or dad's arms, you can go off the character reference a little bit, I suppose. Respiratory wise, so I think if we were doing this as more of an interactive session, I'd ask you a little bit about some of the respiratory signs you might be able to see in little ones. It's a bit more subtle than in adult patients who you can probably hear their laboured breathing, but little ones, as soon as they're working hard with their breathing, you'll see recessions, so intercostal, subcostal, you get quite good going tracheal tugs sometimes, and we talk about head bobbing, and that's all a sign that a little one is having to use accessory muscles to breathe, which obviously isn't a great sign. Remembering that parameters alter very differently, so what's within the normal range will change from month to year from 4 months will be different to a year old, will be different to a 4-year-old. So it's knowing what's normal for that age group is really important. And I think we have a good system on the computers now that will flag up red depending on the age. So you've got a bit of help there, and we often carry around little cards in the PEDS department that help as a signpost for that to know what the normal parameters for that age group are. Obviously listening to the chest is helpful, but in tiny chests, especially because I've got an adult stethoscope, and you're pretty much just listening to the full lungs with your bell or your diaphragm, and it just always sounds pretty loud and crackly, but there's some subtleties that you can pick on throughout the job as to the difference between kind of wheeze, crackles, and obviously air entry is a big thing. Apneas are obviously never a good sign, but that will come under respiratory, so asking about mum and dad if they've seen erratic breathing but also pauses. Circulation and hydration, so we'll talk a little bit later about signs of dehydration, but within that becomes sort of skin turgor, what the eyes look like, so sunken eyes, that sort of thing, your cap refill, which is the same in adults. Looking at the mucous membranes is really important in little ones, so you might see sort of dry mouth, but look in the mouth, see if there's saliva. That's a really good way of seeing and assessing dehydration. Mottling, again, is a sign of hydration status, and again in the history, always asking about urine output and feeding. We'll touch on history taking a little bit in terms of, we got given an acronym as medical students here for always things to ask in paediatrics, and that's BINDS, so that's asking birth history, immunisations, nutrition, so that's how much a little one's feeding, whether the bottle breastfed if they're infants, any allergies comes within that. And then development and a social history. So BINDS is always something that I include. Obviously it becomes less relevant when you're seeing a teenager or even kind of an older child, because the birth history is probably going to have less of an input, because you'll have a bit of a past medical history by then as well. And then other signs, so I think in the table you can see, kind of looking at the how high a temperature is. I mean, little ones can have simple viral infections and they can get good going 40-degree temperatures. It's not always a sign of a worse or a bacterial infection, but obviously if you're getting really good going high temperatures for a sustained amount of time, it might get you thinking a little bit more. Rigors as well is it's not always a correlation, but you do tend to think a little bit more, you know, is this a bacterial origin rather than viral if there's a rigor going on. And always thinking about where the infection could come from. So we've got our basics. Normally it's an upper respiratory tract infection in little ones, but obviously listening to the chest, thinking about urine. Meningitis obviously is a huge one, so it's hard. We'll talk a little bit about subtle signs of meningism in infants who can't tell you that they've got neck stiffness or photophobia, but also looking at limbs. I think often we forget to check all the limbs, and mum and dad might not have noticed a slightly swollen red little knee. You think they might when they're stripping them off, but it's something that can be missed. So septic arthritis, and obviously looking for any sign of rash is a big one. There we go. So I think we've touched on this a little bit already. So I chatted through signs of increased work of breathing, some sounds that might be concerning. So I know in med school we talk about kind of grunting, talk about snoring. Stridor obviously is a worrying one for a upper airway obstruction. And again, that grunting and snoring is all signs of not really maintaining your own airway. And grunting is a sign of having to work a little bit harder to force that air out. In terms of meningism, so we're talking about thinking of source of infection when a little one comes in feverish. Obviously children, maybe older children, can say that they feel like their neck's a bit sore or they've got a headache, but you've got no chance of eliciting those sorts of symptoms in little babies. A big thing we talk about is irritability. And that's a real buzzword in peds, and you don't want to use it lightly. So you'll get parents coming in saying, I think little so-and-so, Lola Rose, is really irritable. And what they probably mean is they're just miserable and can't be bothered. But real irritability, once you see it once, you never really forget it. It's kind of an inconsolable, high-pitched crying. You see this kind of agitation and movement that you never really see in a bit of an unusual tone in a baby. It's kind of the opposite of that floppiness, but it's as if not more worrying, really. So irritability will be a big thing in children. You might be able to assess kind of a subjective photophobia. So obviously we have horrible clinical bright lights in our A&E departments, and whether that heightens, and if you turn the light off and they settle down a little bit, I guess you could cling to that being photophobia. And then in terms of meningism in general, if that's causing a sepsis, then you'll have your normal things of reduced oral intake, reduced urine output. Your parameters will all be suggestive of a sepsis. So tachycardia is high respirate. Like we said, we don't really look at BP or weight to rely on that. And in little babies, it's difficult to do quickly. And yeah, looking at the fluid status, really. Obviously a big thing in although you can get meningism without a meningococcal rash, but you're looking for those non-blanching rashes, and purpura petechiae. So yeah, looking at signs of dehydration, So history is a big thing, so looking at feeding history and urine output. So infants, we tend to do a bit of a calculation to help us. So up to about 1 year old, when they're probably more like 6 months really, when they're mainly relying on milk as their food and fluid intake. You want a baby to be drinking at least 100 millilitres per kilogram per day. So in 24 hours, but if they're well and really well hydrated, a normal child should be drinking 150 mils per kilogram per day. That'll often be, parents still use ounces, so you have to do a bit of maths there. But if a child's taking less than 100 mil per kilogram per day, that, you know, you're getting a little bit more worried, and they might need a little bit of help. So NG tube feeding, and it might be you're thinking more of an admission there. Especially in sort of our bronchies that we see in the winter, when it's conservative management really, but you give oxygen and feeding support if needed. So we use that, but you get a bit of a hunch as to if mum and dad are saying they normally take 6 ounces every 3 to 4 hours and they're only taking 2 every 5 hours. You can think, okay, they're not getting even half as much as they normally would. So that's kind of looking at the history. So again, this is from the NICE guidelines, but it's talking about when it would warrant further investigation when a little one comes in with a fever. It's kind of age plays a big part. I think in little ones that are under 1 month, you rarely don't do anything. If a little one comes in with a fever over 38, we do investigate. We have a low threshold for investigating and doing the full hog. But the NICE guidelines split it into kind of under 3 months initially. So if you're good 3 months with a fever of over 38, you pretty much always do a partial septic screen. So that's your full blood count, blood culture with a CRP, urine test if you can. We tend to put little pads in. Obviously it's difficult sometimes, especially if a little one's dehydrated. Consider a chest x-ray, would do a chest x-ray in an under 3 month if you had a high suspicion, and a stool culture if they've got loose stools. Performing an LP, like I said, we've got a very low threshold, so any infant under 1 month, you're going to have an LP, really. Infants 1 to 3, if you've got a real clinical suspicion that they look unwell, and infants 1 to 3 if your bloods come back with a very high or very low white blood cell count. And then older than 3 or older, again we're splitting it into kind of red, amber and green features based on that traffic lighting as to what you would do. In practice, especially as when you talk to certain consultants and things, they'll have they've got a wealth of experience and don't probably need to refer to this, but I felt like it was quite a good guideline in my own head as to when I'd warrant to do certain things. So if older than 3 months or older than that, and they've got red features that we were talking about, so that would include some things like grunting, increased work of breathing, mottling, and any of our severe signs of kind of dehydration. You do your full blood count, blood culture, CRP and urine sample, and you would consider a chest x-ray, LP. We tend to do blood gases quite readily because they're really easy to do, and nurses do a lot of cap gases, so that's just a BM prick, and that can give us some useful things. It's difficult because sometimes when it's squeezed it can change the numbers a bit, but it gives us a good sense of lactate, pH, acidosis and that sort of thing, so that's quite a good and easy thing to do if you're having difficulty with access. And then with amber features, so if a child comes in, we get this a lot, a child comes in with a fever and you can't really find a good going source. So that's when you've had a look, you can't hear anything on the chest, they're not coming in with a nasty cough, they're not really snotty, and you look in their ears and their throat, and normally with an upper respiratory tract infection you get good going bilateral redness of the canals, you have a really snotty child, and you look in their throat and there's good going pharyngitis, and you're pretty sure that that's the source. Or they're coming in with if they're an older child, a bit of burning when they're passing urine, and you're going to check the urine at that point. But if you don't have an obvious source and you have a bit of a hunch with these amber features or something that's not quite right, so one or more of those amber features, then you want to be doing a little bit more digging. It's not I don't think it's good enough at that point to just send them home thinking, well, it's most likely going to be an ERT or upper respiratory tract infection. You're not really covering your back there, and you don't want to be missing anything. So urine's an easy one to do if they are passing urine, and then you would do your bloods. LP you'd consider if they're under a year with one of those amber features and no obvious source. Chest x-ray if the fever's a little bit higher or they're complaining sort of abdo pain's quite a big one in pneumonias in little ones. Don't tend to present with like adults with a good going cough and sputum production because they're not as good at coughing up that sputum. And if a white blood cell is over 20, you're thinking, oh, that's probably bacterial rather than viral. CRP, I just want to touch on that quickly because that can dig us quite a few holes when we do that. Often, I know from my experience anyway, we've done bloods, white blood cells seem to be all right, and then we get this CRP of kind of 50, kind of in a middle zone. I think if the CRP is kind of under 10, you're pretty happy that you're not missing anything massive. But I know we've kind of admitted on the base of CRP sometimes being just kind of in that rumbling middle grade, and sometimes you can dig yourself a bit of a hole with it. But you'd rather be safe than sorry with little ones. And if there's not an obvious source and you've got a CRP that's kind of sitting in the middle there, then you're always better to observe a bit. You don't necessarily have to jump in with antibiotics, but yeah, CRP is a funny one. And then green features. So if you're quite happy actually that a little one isn't showing any of those red or amber signs, then you don't want to unnecessarily be doing bloods on little ones. You know, it's quite traumatic. It's really difficult, and it's horrible for parents. And if it's not going to change your management, I think what's really different to adults is that you go in thinking we're not necessarily going to investigate this, and it's a lot of clinical judgment, which at the start of being a junior is quite scary, because I think on adults you often go in and they've got bloods every day, or you go into adult A&E and they've already got bloods and a chest x-ray waiting before you even see them. But in peds you're rationalising everything, so you just think, okay, we don't need to over investigate this, because if I'm quite happy actually parameters are fine, they're eating and drinking now, they're passing urine, the temperature's down and they look a lot more themselves and I can see an obvious source, then you don't want to be rooting around with bloods and a chest x-ray. Yeah, so we touched a little bit on assessing dehydration. In peds we tend to separate them out into mild, moderate and severe dehydration. This becomes more important when you're trying to do sort of fluid replacement, especially in DKA management, which is a bit complex and we won't touch on today, but it changes and alters what fluids you give. So assessment of dehydration, I know we've touched a little bit on blood pressure and that you don't want to rely on that solely, because when it's low you're probably a bit too deep in. Heart rate is a big one. So like I said, tachycardia, it can be a subtle change, but a raise in that without kind of a temperature, actually maybe that little one is a little bit dehydrated. Skin, so skin turgor, so when you're sort of pressing it should just spring back, there should be elasticity, but if you're finding actually that it's sort of staying quite pinched, I think once again it's one of those experience things. Once you've felt a decreased skin turgor, you will remember it, so knowing the normal and the off. Fontanelle is a big thing, so your fontanelle your anterior fontanelle remains open until normally about 1 year old. Sometimes it can be a little bit later or a little bit earlier. There's kind of a range of normal, but feeling that at least in under a year old, you can feel that it's nice and normally it's present, it's kind of bouncy and it's not bulging, but again, once you've felt a really sunken fontanelle, you won't forget it. Looking at mucous membranes, like I said before, so there's a good bit of saliva in the mouth, lips, are they dry, and other mucous membranes, so around the sort of nasal cavity and things as well. Looking at the extremities, so feeling, are they warm to touch? Where sometimes when little ones have a temperature, they can be quite cool, although they're centrally really, really hot. Looking at the cap refill and mottling is a big sign of that. And again, we talked about activity, mental status all plays into that same thing. So whether they're lethargic, are they interacting with you? Can mum rouse or dad rouse them from sleep in their arms, or are they just flopping back down? And urine output is obviously a big part of assessing hydration. Yeah, so just moving away from that little bit, I know I've waffled a bit there, but they're sort of the mainstay of a feverish child presenting, which is probably the biggest thing you'd see in peds, especially in a paediatric A&E setup. So going to the littlest of our spectrum, so we don't do much neonates here as juniors, but obviously we get some neonates coming through the A&E department. So that is under 28 weeks. And one of our registrars did us a good talk the other day about the 5 things that a neonate should do. Quite simple beings, really: sleep, wake, feed, poo, and wee. If any of those aren't happening, or they're not appropriate, and they're not in balance, then you need to be concerned. Essentially, in a under 28 day old, or even up to kind of 2 months, you can't trust them with anything, and anything that's kind of subtly off, you have a really, really low threshold for suspecting sepsis or anything like that. They've had no vaccinations, they're reliant on mum's immunity, they've been through, there might be some risk factors for sepsis in the birth history, and they can't tell you a thing. So we have a very low threshold for investigating any sort of unusual behaviour in neonates. So when we're talking about things not being appropriate, it might be that their feeding's gone off, it's a bit more erratic, they're not waking for feeds, they're not wanting their feeds is a big one. If weeing is, normally you should have incredibly heavy nappies, so if the urine output goes off, obviously that's a big thing, and there should be a balance between sleep and wake. We get a lot of parents coming in twitched because a little one is sleeping too much or just not sleeping at all, and I think in the first few weeks obviously they haven't got a circadian rhythm like us, so they're going to be erratic, but I think you get more and more used to what's normal. So as long as they are sleeping, or they're not sleeping too much, then you don't need to worry too much. So essentially, if anything is either subtly off, even without a temperature, so even something like crying more than normal or poor feeding, that is new for that little less than 28 day old, we pretty much do the full hog, so do a full septic screen. So we get lots of under 28 day olds getting LPs. It sounds horrid, but they're quite easy in that age group, and it's not something you want to miss, and there's unusual bugs that can cause meningitis at that age. So crying is a big one, and obviously crying is normal, but it should be consolable. So normally a feed, having a poo can settle them down. Sometimes it's just that they just need to pass something, or having a wee or being in a wet nappy can make them cry, but it should be consolable at some point. So when you're observing, you should have those moments of a baby comfortably sleeping and being consoled and quiet. A head to toe examination, so we pretty much do a full baby check when we see a neonate, and you don't want to miss anything out. So some things that you might not do in a slightly older infant, but always checking the femoral pulses and making sure they're equal and they're good character, because you can't really feel a radial pulse. Fontanelle's a big thing. So a full head to toe. And as I touched on earlier, birth history is really important, because there's not many days that this little one's been alive. So the risks for them are what they've been through during the pregnancy, what they've been through during the labour, how they've been delivered, what mum was like during pregnancy and labour. So big things that we always think about are premature rupture of membranes. So if mum has had a rupture of membranes more than 24 hours before she's been in labour and not been covered with antibiotics, or maybe has but it's been late, that's a massive risk of infection tracking up into the uterus. Mum might even have had chorioamnionitis. She might have had antibiotics during the labour. And a big thing to ask about is GBS. If a mum doesn't know what GBS is, then she won't have got it in her, she's not carrying it, normally anyway. Yes, and obviously if a little one's had a temperature at birth and treated for sepsis initially, that is vital to know, and any prematurity ups the risk of everything, essentially.
And then the other thing is, obviously there have been some cases of coronavirus in very small children as well, in very young children as well, recently as well, with the mother
having had it
Yeah.
in pregnancy. Yeah, it's an interesting one because I think obviously that was our main a big scare in peds in general, but also for the neonatologists. I don't know much about it, and I've not heard of if there's been cases in Sunderland. I know we maybe had a couple of mums who had it, but the babies have been fine. But obviously this age group are at heightened risk of everything. But yeah, so that's kind of more of a topical. I don't know too much about the cases that
I imagine you won't have seen, because obviously the largest centre is the RVI.
Yeah.
So that would be. I would imagine you'd like to think that most of the cases would have gone there.
Yeah.
I haven't seen any of the northeast in the news, so
no.
I'm not sure.
No, and I think we've had maybe everyone got quite excited that we had a couple of kids with one of the sort of inflammatory process.
It's like a rheumatoid.
It's
polyarthropathy.
And just a kind of inflammatory, a bit like I've forgotten the name of it now. Kawasaki's disease.
That's it.
But whether we've just had a couple of patients that had Kawasaki's, but and apparently all the bloods fitted the markers that we were told were to look out for. But I think people were just getting a bit excited because peds have been left out of COVID.
Twitter's got very excited about that.
Yeah, but no, luckily we've not had any burden of COVID. I think we've had one positive case on the ward, and that was a little one that didn't have any symptoms of COVID. It was kind of incidental, so it's good. Yeah, touch wood. So yeah, I'm just going to touch on, a lot of you might not have heard of this, or you might have and not know much about it, but I know it's something that I hadn't really touched on until I started working in the A&E bit. I'd heard of something called ALTIs, which are acute life-threatening incidents or events, which sounds really, really scary. And the new name it sounds a lot nicer, but brief, resolved, unexplained events. And these are quite specific, but they're essentially events that we never really explain. And are scary at the time, sometimes even require a mum or dad to initially start CPR, although it probably wasn't warranted, but there's no actual identifiable medical condition or concern. It's obviously a diagnosis of what's the word? Diagnosis of exclusion. So you never want to be bold enough to be like, okay, cyanosis for less than a minute, or a floppy episode, obviously a BRUE, but it's all about risk stratification. And we tend to, with the patients that come in with this, or the infants that come in with something that sounds like this, we never discharge being like, this is a BRUE. We always admit it's a bit of observation, but it's whether you investigate further really that this is touching upon. So BRUE stands for brief, resolved, unexplained event. It's got a very specific definition. So it's an episode in an infant less than 1 year, characterised by less than 1 minute duration. So it's typically seconds really, so a fleeting moment really that mum or dad have picked up on. It's followed by a very quick return to baseline, so there's no kind of postictal state, there's no weird behavioural or colour change that persists, and it's not explained by any identifiable medical condition. So it can be a variety of things. So I've seen a couple that we've put down to BRUEs that have been kind of quite weird and wonderful, like blueness all down to one side, or just seconds of pallor, kind of a slight apnea or decreased irregular erratic breathing pattern, marked change in tone that could almost, parents maybe think of seizure activity, but again fleeting and no postictal state, or a slight altered level of consciousness. So it's about risk stratification. So they partition it into high risk and low risk. So high risk, infants under 2 months, if there's a history of prematurity, especially if really prems are under 32 weeks, and if there's more than one event. But also if you dig further and there's any family history of cardiac stuff, any social concerns, because unfortunately with these you do have to think non-accidental injury, safeguarding, or any feeding problems, because you see some really weird things with reflux in babies that can mimic this. So sometimes a baby will feed and then the whole of their colour will drain, but you'll dig a bit further and it'll be arching back. It'll always be after feeds, and they maybe have had a little choke on their feed. Low risk is age under, I I think that means over 60 days. Born over 32 weeks gestation. No CPR warranted or needed. It's the first event and under a minute in total duration. It's all about not trying to not over investigate all of these, especially when it's a fleeting for a few seconds, and when you examine them, they examine beautifully. You don't want to rush in and be doing bloods, LPs. So it's about not over investigating, but obviously having your differentials there, and also I guess not missing the chance also that it could be presenting sepsis, especially in, like we said, the neonatal group. So if it's low risk BRUEs, you consider the non-invasive stuff, so urine, ECG, BM, and then like I said, we're never often bold enough to send them home without observing them, because like I said, it might be the first presentation which is low risk, but if they have another one overnight, they're then in the high risk category, and you've missed the opportunity to investigate, and you might have missed the opportunity to diagnose something else. So often we observe them overnight. They'll be on sort of continuous monitoring maybe for a little bit, and it gives the chance, and also a bit of maternal or paternal help and reassurance.
I guess this is kind of the adult equivalent when you kind of get a pain in your hand or something like that and it goes away. After seconds you kind of write it off. I guess that's the equivalent.
Yeah.
And it's, in yourselves we might not worry about it, but in a child it's more difficult to work out.
Yeah, no, that's a really interesting way of putting it. Yeah, because I know we all will all get weird things that happen for a few seconds, and you in your head you're like, well, if that happens again, I might ask someone about it. Yeah. But yeah, you don't have the benefit of, you don't have a little one to be like, oh yeah, no, it felt a bit weird at the time, but it's over now and I'm back to normal. So
and I guess they have less cardioembolic and cerebrovascular risk factors as well by nature of being babies.
Yeah, exactly.
Smoke,
they've got a new body backing them, really, haven't they? So you're right, it's a blank canvas of hopefully not too much damage. Yes, and also something that I hadn't really seen or thought about before starting the job is that they can get really weird vasomotor stuff. So if you think in those first few weeks of life, your vasculature and you're getting used to being in the outside world. So like I said, we saw one little one who just seemed to have moments of one side of their body just going blue, and I think you can get things called like harlequinism, and it's all within the normal, but you get some vasospasm, vasoactive stuff, but they're otherwise well and interactive, just a bit odd. But yeah, something that we always need to consider in these though is that are we missing some kind of safeguarding concern and child protection. So looking for, we always do a head to toe, but looking for any unusual bleeding or bruising in non sort of bony prominences, especially in a immobile child, and looking for changing, or if you ask mum and dad, they have different versions of the history, that sort of thing. Yeah, so I think this would need a whole presentation on its own, really, and I don't think this quite does it justice, but we'll touch on it. So never forgetting non-accidental injury. So there's 4 main forms of child abuse: there's physical, emotional, sexual, and neglect, which by far is the most prominent we see, and can do with some more support for parents and child. How might they present to A&E? So often the main thing that we see or pick up on is that kind of a delayed presentation of things, changing stories, but when it's just kind of on examination, so it might be that a child's come in for a bronchiolitis, but you notice that there's bruises on a child that's not mobile, so it's very odd to be getting bumps and bruises to the shins and the knees and the elbows if a little one that cannot even roll over yet. If they're multiple or clusters, so sometimes they can even look like a petechial rash, especially if it's kind of a burn or something like that, where sort of I guess you'd call it a Chinese burn when you're young, but grabbing. If they're similar shape to something. So if a little one's been slapped or something, you might see a hand or finger, and any non-bony parts, because it's hard to, normally if you knock something bony, then you're going to get a bruise, but if it's on kind of the face, the cheek, buttocks, somewhere that isn't bony, that's at more risk of bruising. Scalds, you should always deeply investigate and look into the history. If it's glove stocking distribution, if they've been dunked in something warm, and if it's sort of sharply delineated borders, so you're thinking actually there's something that someone's put, sort of a cigarette butt, anything like that. Obviously scalds happen all the time. We've had loads through COVID actually, because little ones have been in the house more, there's lots of cups of tea lying around, and most of them are just accidents waiting to happen, but you do just need to think through.
Straighteners, I've heard.
Yeah, we've had lots of straighteners. Yeah, mum or dad have left straighteners on the floor. So yeah, it's just thinking about the history. Does it match? Is it an unusual place to get it? Is it something that child could conceivably have done themselves? And whether mum and dad have seen it straight away, been horrified and come straight to A&E. Fractures, obviously little ones break things, they've got more malleable bones, but definitely more at risk of fracturing. But you need to think about where the fractures are and whether that is suspicious. So obviously any rib fractures in a little one would be highly suspicious, but also sort of fractures in unusual places that wouldn't happen, and of different ages. So if you did an x-ray and actually you saw that there was one that was ossifying, that was calloused formation, so that's kind of older than the other ones of and fractures of different ages, and also so one or more fractures in the absence of a medical condition like osteogenesis imperfecta that would obviously explain high risk of lots of fractures. Intracranial injuries, which is a horrible thought, but you can get spontaneous subdurals in little babies, but if there's multiple ones, or if any sign of retinal hemorrhage, unfortunately that's a real indicative of shaken baby syndrome, which we do see a little bit of, and horrible. But yeah, so like I said, it's the darker side of peds, but it's so important, and I think as a junior it's quite a scary thought to be the one to pick up on it, and the seniors in our department are amazing, because the one job for us is escalating. So you would never be put in that position of having to necessarily even talk that through with a parent. But if you feel confident to sort of raise the concern and say we are looking into this, then that is it's one of those kind of difficult communication stations, as it were, that is important to try if you feel confident. But senior support is always there, and it's something that needs to be done properly. So yeah, our job as juniors, escalate when you've got any whiff of concern, document everything. So I mean, as you can probably tell, I'm quite waffly anyway, but in my documentation I am, and I think paraphrasing is really, really good to do, because you're not making any judgment then. If you're paraphrasing what mum and dad have said and what you've said, actually physical quotations even, then you can do no wrong really, because you're not making a judgment, but you've got some really objective evidence there. And we use photographs a lot, so we've got a special camera which is, I think, only the consultants can use and save onto a file, but you have to photograph everything, because especially with bruising, it could evolve that in the next 2 hours it's gone, but if you've seen a bruise that's been suspicious of kind of a hand mark or something, it may well go within the next day. So you definitely need to photograph everything. Brill. Yeah, so I don't know what time we're on, but we might have just a little bit of time to touch on some paediatric prescribing, because obviously it's quite different to adults. There's a lot more calculation involved, but also I think because I was a bit, oh gosh, it's going to have lots more steps to it, you can probably make more mistakes, but actually you tend to use the BNF a lot more and you calculate it, but I think you probably end up making potentially fewer mistakes then, because you're not relying on your memory as much. And if in doubt, just always check the calculation with someone. So obviously weight's a big thing, so every child that comes through A&E will be triaged with a weight. it mostly tends to be that prescriptions are based on weight. Obviously we have some difficulty, especially in this day and age. We do get quite a lot of larger children, so their weight might mean that they can have a whacking dose of paracetamol that you wouldn't even give to an adult. But you have to think, actually no, that isn't that's way too much. We'll go off their ideal weight or their age. So and BNF tends to have age categories as well. And body surface area, we don't tend to, is not for many drugs, but acyclovir is one that I can think of, IV, that goes off body surface area, and it just takes a little bit of calculation, but there's a lot of references in the BNFC that if you've got a weight, it will calculate the body surface area for you. So again, it's more simple than it looks and sounds. So in sort of a research situation, you might not have time to take a child's weight. It's not your priority. So we have some really good things called spark charts in research, which basically has all the major research drugs based on a weight. So you'll go off ideal body weight for that age. And it's got it all laid out, including this thing that you might have heard of, wet flag. So as soon as you have a resus call put out for a child, so you might have 2 minutes before the ambulance arrives, there'll be someone frantically writing down wet flag on the whiteboard, and that's just on the side of the screen. So W is for weight. Again, you can use ideal body weight for age if you're struggling, but it tends to be age plus 4 times 2. And that's the research guidelines calculation. E is for energy, so that's your shocking rhythm, shocking energy in joules. T is tube, so if we're going to need to tube them, useful for ITU, and you'd have one above and one below ready as well for ITU in case you need that. Fluid, so that's your bolus, 20 ml per kilogram. Lorazepam is L for obviously if you're having a fitting child. Adrenaline, and that will be that's the dose for CPR rather than for anaphylaxis. And G is your glucose if you've got a hypoglycemic child coming in, or you notice that they're hypoglycemic. Analgesia, what do we need to be careful and why? Oh yeah, so in peds we rarely use codeine. So I think there's some discrepancy. Some people don't use it in sort of under 12s, others not for even sort of under 14s, and that's because kids can be variable metabolizers of it. So you might give it to one child and they don't feel a thing, and another one can even go into sort of respiratory depression with it because it's a pre-metabolite of morphine. So we tend to veer away from it really. So yeah, there's a few questions here. So obviously we're doing this as a kind of video, so we won't do it interactively, but you can do these in your own time if you like. But so this is quite a simple one, and we get asked to do it a lot, especially for our surgical patients. So IV paracetamol. This one is looking into and just making sure that you're looking at the maximum dose. So if you work through this, the answer. I won't give you the answer now, but what I can do is, I don't know, Michael, if
we can put the answers in the bit below.
Yes, I'll put the answers in the bit below. But yeah, so this one's an example of paracetamol, which is there's no trick about it, but it's just thinking as well, because in peds, obviously, when you're doing lots of calculations, you'll come out with some numbers that the nursing staff will be like, well, not ideal for us because we're going to have to draw 0.5 ml here, and you've just got to be a bit kind to your nursing staff as well. So so just thinking about the vials you've got to use. Acyclovir, this is a example of your body surface area. Again, no trick here, but it's just thinking about your units. So making sure that you remain in your milligrams or your grams and that sort of thing. And then this one, so this one's a little bit difficult. If you have any issues, I can always get back in touch with Michael or anything, but this is looking at your prescribing maintenance fluid. You can probably find some help online, but essentially when you're doing maintenance fluid, we talk about a calculation of either 4-1 or going off your first 10 kilogram of weight, second 10 kilogram of weight, and then so forth. So for example, we've got the 23.4 kilogram child here. So they're 23.4 kilograms. So the first 10 kilograms for them, they'll get 100 mils per kilogram. So that basically means they already have a litre. And then for the second 10 kilograms, it's your 50 mils per kilogram. So they've already warranted 1,500 mils. And then you've got your 3.4 kilograms for that last bit is 3.4 kilograms times 20 mil. So that will give you your number of mils over 24 hours. So once you've got that, you need to divide by 24 and then you'll get your answer. Okay, sounds simple, but if you have any issues, I'll put a little working out of these for you for Michael to put on. Yeah, so covered a lot there. Sorry if it was a bit here, there and everywhere, but I think it was just, I tried to go through some of the salient things that have come up for me. Like I said, not all of you will, well, very few of you will actually do PEDS jobs, but I think it's useful just to know about your little population, some of the nuances, and then if ever you, because a lot of you will probably end up doing adult A&E at some point, and we're a rare hospital to have it separated out, so you will be seeing some PEDS and not having had a lot of experience on it. So yeah, hope it's been useful, and I think it was just a topic because I am, having done 8 months on it now, a lot more keen on, I think PEDS is what I want to do, so it's been quite a nice thing to do a bit of a teaching on, so I hope it's been helpful. Bill?
Thank you for the talk, Maddie.
No worries.
One thing I was going to ask is about safety netting,
Yes.
which I imagine you do all the time.
Yes. Yeah, it's you get quite a good patter on it. Yeah, that's a huge thing actually. It's a good thing to have put in. But yeah, so safety netting. So it's funny when you first start, if you do a PEDS job, because you feel like actually often you don't really do much for the child. A lot of it is you'll observe and, like I said, watch and wait a bit. And often your main management is managing the expectations of the parents and reassurance, but also knowing that you've only seen a child for a tiny bit of period, a tiny amount of time, and that things can really quickly change for a child. So safety netting is absolutely vital. So when we're talking about a child who's come in feverish and you're worrying about sepsis, you need to relay those obvious signs to a parent of what is actually more worrying and what's pointing towards a sepsis picture. So that's saying, do come back if you're worried that at any point, even when the temperatures are down in a child, they're floppy, drowsy, lethargic. A big thing is oral intake. So if we don't really mind too much about food, because I think we're all off our food if we feel a bit crap. But as soon as fluid input tails off, it's a sign that a child, its activity level is lower, and GCS is, mental state is lower. And also that they're at risk of dehydration eventually, and urine output. And then obviously looking for signs of obvious sources, so any non-blanching rash, any increased work of breathing, so safety netting is a big thing. And I think always making sure that you don't just, because I think especially once you get used to doing the same pattern over and over again, making sure that a parent fully understands, because you get a whole range of intelligence level as well in the parents that you're trying to explain things to. And I think sometimes I've come away and been like, you know what, I'm not 100% sure that parent would know what to come back with, and that's a horrible, and then you don't sleep because you just think they're gonna go septic, and the parent will be like, oh well, I should, so anyway.
I don't think you can mitigate from that. We were talking before about some of our experience. I haven't done a paediatric job, but I remember a 4-year-old came, typically the last patient I saw on a Friday in a GP job, and she'd had a bit of a cough, and she was absolutely fine. She was playing with my stethoscope, and luckily I had some teaching on all the red, amber, green assessment kind of thing, and I documented it, and I safety netted, because the child looked absolutely fine, and then I got a letter a week back and they'd had double pneumonia and been in hospital, and sometimes they take them into hospital, and that's how safety netting works. It means that if you're wrong, and that happens, you can't predict the future. If a child's playing with a stethoscope, that's a pretty good sign. And that's how safety netting can be reassuring in some ways for you as well as the patient. If you're forever defensive, that makes it more complicated for the patient in some ways. Yeah, you're right, and it's a real tool that you can use, and also it doesn't mean that you're wrong because you've seen
you've seen that snapshot.
Then there.
And things do take time to develop. And actually, you know, yes, you're an advocate for the child, but so is the parent. And so I think that's your real tool, really. And I know some people find it incredibly dissatisfying that is the main tool that we often use. But actually, I think there's a real satisfaction in getting it right and feel like, because I remember, especially because I started in December, and every patient I saw was bronchiolitis pretty much. And I remember maybe the first 2 weeks I had about 3 patients that came back. Yeah. And I remember thinking that was a failure initially, and then I was like, well, actually, looking back, it was a really good learning experience, because looking back at my initial documentation and things, I was happy. Then if I'd seen that child again like that, I would have sent them home. But the thing with bronchiolitis is it's a daily change. And actually you've done a good job if they come back and actually then they're needing the admission, because the parents have looked out for the right signs.
That's really good, actually. That's a really good point, actually.
But so don't feel disheartened, because it is horrible when you when you see the same name you've seen like a couple of days before.
But I think if they remember the advice, then that's a positive thing.
Yeah.
Actually, if you can go back and it's absolutely, as you said, that's a really good thing.
Yeah. So.
That's really good. It's always embarrassing. No matter how much we tell ourselves that we've done the right thing, it's always embarrassing.
I had one that came back in the same day. I think I'd safety netted too hard with that. She was like, she said if she had any more vomiting, and I was like, I didn't really say it like that, but oh dear. But better safe than sorry.
That's lovely, Maggie. Thank you very much. We'll
no worries. Fab.